concept of intra-arterial thrombolysis has evolved. And the first time somebody tried thrombolysis was actually in 1950s. So it's been almost like 70 years that this process has been going on. But I think that in the early 90s, it really started becoming widely adopted or widely considered, just because the concept of time window became more clear that, you can give or you can do endovascular treatment, but in a particular time frame, and only then you see benefit. And initially, it was really focused on giving intra-arterial thrombolysis. So simply putting a catheter and giving intra-arterial thrombolysis. But as people were doing intra-arterial thrombolysis, they started noticing that just the microcatheter manipulation in the thrombus was actually causing some level of recanalization. And it started evolving this concept that perhaps a mechanical component was also beneficial. So then in the next 10 years, you start seeing a inconsistent use of mechanical devices. And the initial devices are more like just the angioplasty balloons and actually even like specialized microwires. And then you have a period somewhere between 2005 to 2015 where more specialized devices are made, devices that just targeted removing the thrombus. So you have the stent retrieval catheters, and then you started noticing that maybe suction itself can retrieve the thrombus. And suction catheters improved a lot. I think the catheter technology improved to the point that you could actually take larger catheters all the way up into distal middle cerebral artery, distal intracranial arteries, and apply an appropriate amount of suction that was enough to retrieve the thrombus. And interestingly, if you look at the stent, even though the initial data for thrombectomy really was derived by stent retrieval, so all the benefit that was shown by mechanical thrombectomy was derived by trial that actually used stent thrombectomy. And the initial American Heart Association, American Stroke Association, and Guided emphasized on that mechanical thrombectomy, the data really was coming from stent retrievals. But then several trials have shown equivalent results with suction thrombectomy or aspiration thrombectomy as compared to stent retrievals. So the advantage with aspiration thrombectomy is faster. I mean, you just put a catheter, you go straight up where the thrombus is, and you do the aspiration. So I think where we are, we probably have to say that both are equivalent. In terms of practice, it's a combination. I think most institutions are using a combination of both in each individual patient based on the characteristics of the procedure or what they're observing during the procedure. So it's actually been hard to say that only do aspiration thrombectomy or only do stent retrieval. I think that's just practically is not possible right now. So it's always been a combination. And even when stent retrievals are being used, there's always a component of aspiration that is being used as an adjunct to stent thrombectomy or a stent retriever-based thrombectomy. One of the concepts has been that, currently what we use is continuous suction during aspiration. So once the catheter and the thrombus have made contact, you actually just apply a suction and you retrieve the thrombus. Is it possible that when you're retrieving the thrombus, you're using a combination of intermittent suction, perhaps that with the cyclic suction, you're engaging a different part of the thrombus, or perhaps actually moving away from the trajectory of the initial suction and making it more effective? I think that remains to be known. It's not completely clear that adding this component really would actually increase the ability of aspiration thrombectomy in achieving recanalization. So that's kind of where we are. And I think that both techniques are being used in somewhat, practices that are somewhat defined by institutional beliefs and institutional experiences. As we move forward, I think that, perhaps the number of improvements in these devices is going to be limited. I think these devices are already achieving recanalization, or at least a combination of using both devices, achieving recanalization somewhere between 85 and 90%. So I think that you probably are not going to be able to see a lot in terms of improving the devices. But perhaps, as we talked earlier, that the optimization may come from the adjunct component, which whether it's actually intra-arterial thrombolysis It may actually be intra-arterial or intravenous glycoprotein 2B3A platelet inhibitors. But that's, I think, where more advancement is expected.